Welcome to The Explainer. Today, we're taking a set of complex clinical guidelines and translating them into some seriously actionable bedside insights. We're going to take what most people just brush off as a basic, everyday hygiene routine and reframe it as a critical neurovascular medical intervention. We're talking about the post-op Sitz bath. And more importantly, we're going to see why nailing the precise timing of this therapy is literally the difference between rapid healing and absolute clinical disaster.
To really grasp why this matters so much, I want you to picture a scenario. It's 2 a.m. on the post-op ward. You've got a patient who's about 12 hours out from an extensive hemorrhoidectomy, and they are pacing the floor in absolute agony. They can't void. It's an acute pelvic floor spasm. The pain is skyrocketing, panic is setting in, and a junior resident is right about to tear open a urinary catheter kit. We'll stop right there. Dropping an invasive catheter at this exact moment risks major urethral trauma and practically guarantees a nasty infection. So how do you solve this agonizing spasm quickly, safely, and without the tube?
The exact solution to this 2 a.m. puzzle all comes down to the number 15. Specifically, placing that patient in a warm sitz bath for exactly 15 minutes. Hit that precise window and the pelvic floor actually relaxes. The intense pain melts away and the patient voids spontaneously. Crisis completely averted. But it begs a question, right? Why exactly 15 minutes? Why not 5? Why not a 30-minute soak?
Well, here's how we're going to break it all down today. First, we'll look at that 2 a.m. clinical puzzle. Second, we'll dive into the pain, spasm, ischemia cycle. Third, exactly why 15 minutes matters so much. Fourth, we'll check out the global guidelines. And finally, we'll wrap up with some critical post-op clinical pearls.
All right, let's jump right into part 1, the 2 a.m. clinical puzzle, moving way beyond basic hygiene.
You see, the core of this puzzle really stems from a massive misconception. So many practitioners, and patients for that matter, just look at the sitz bath as a way to clean up down there, completely missing the profound medical mechanism at play. Think of a spasming internal anal sphincter after surgical trauma like a ridiculously over-tightened high-pressure pipe valve. If you try to force fluid through that, you're just going to cause massive structural strain and blinding pain. But a perfectly timed, warm sitz bath, it doesn't just clean. It acts as a highly effective thermal lubricant. It physically expands the neurovascular system, forces that tight valve to finally relax, and allows local blood circulation and lymphatic drainage to seamlessly resume.
Which leads us perfectly into Section 2, the pain spasm ischemia cycle, a truly destructive chain reaction.
This right here is exactly what's going wrong at the cellular level after surgery. We're dealing with the pain, spasm, ischemia cycle, and it is a brutal, self-worsening loop. So the sheer trauma of the surgery kicks your sympathetic nervous system into overdrive. This causes severe hypertonicity, or spasming, of the smooth muscle fibers in the internal anal sphincter. Now, here's where it gets dangerous. That sustained spasm literally clamps down on the microscopic intramural arterioles that supply blood to the area, starving the local tissue of oxygen and causing ischemia. And the tragic irony of this whole loop, that ischemia directly worsens the pain, and the increased pain violently worsens the spasm.
Let's trace this 3-part chain reaction just to see how fast things can go south. Step 1, you have surgical trauma to the anoderm kicking the whole thing off. Step 2, smooth muscle hypertonicity locks the area into a rigid, painful spasm. Step 3, local tissue ischemia restricts vital oxygen. If a patient skips their sitz baths because we didn't explain the why to them properly, that chronic sphincter spasm just persists. It completely deprives the wound of oxygen and fibroblasts. Left unchecked, that can quickly turn a clean, textbook surgical site into a chronic, non-healing ulcer.
But here is the really cool science behind reversing it. When you get a patient immersed in water maintained strictly between 37 and 40 degrees Celsius, so that's about 98 to 104 degrees Fahrenheit, it fires up local cutaneous thermoreceptors. This thermovasodilation actively blocks sympathetic vasoconstriction, and it triggers the release of nitric oxide in the endothelium. That literally floods those starving ischemic tissues with rich, oxygenated blood. On top of that, the physical immersion itself creates what's called hydrodynamic debridement. Essentially, it's a super gentle, low-pressure cleansing that safely sweeps away cellular debris from delicate surgical crevices, meaning they get to completely avoid the severe frictional damage of dry toilet paper.
Which brings us to part 3, and arguably the most crucial takeaway for today, why 15 minutes matters, or as I like to call it, the Goldilocks window.
You'll see a completely stark contrast in physiological outcomes based purely on time. On one side, we have the immense benefits of that strict 15-minute cap.
You get optimal thermovasodilation, maximum sphincter relaxation, and peak nitric oxide release. It is the absolute perfect dose of therapy. But look what happens on the flip side. If a patient mistakenly thinks, hey, more is better, and stays in that bath for over 20 minutes, they trigger what we call the maceration mistake. Extended soaking heavily softens and breaks down the skin, completely weakening freshly healing wound edges and causing massive structural breakdown. This is exactly why capping that session strictly at 15 minutes is vital. More time doesn't equal more healing, it literally equals tissue destruction.
Moving on to Section 4, Global Guidelines and Protocols. Let's look at the unified medical consensus on this.
And guys, this 15-minute rule isn't just some neat theory we're throwing around. It is explicitly backed by the absolute highest international surgical authorities, including the American Society of Colon and Rectal Surgeons and the UK's NICE guidelines. Just look at the striking similarities when you put them side by side. Both demand pure, plain, warm water. Both rigorously cap the duration at a maximum of 15 minutes to protect that wound edge integrity. Both recommend air drying or a cool blow dryer to avoid mechanical friction. And finally, both explicitly warn against the additive trap. Patients are going to desperately want to add Epsom salts, iodine, or fancy soaps to the water. Do not let them. Those additives cause chemical dermatitis and will literally burn delicate new granulation tissue. Plain water for 15 minutes is the indisputable global gold standard.
Finally, Section 5, Critical Post-Op Clinical Pearls. These are the vital adjustments beyond the bath. Let's translate all this into a rock-solid bedside strategy so the 15-minute treatment works without triggering any secondary complications. First up, the orthostatic warning. That warm bath causes splank neck and pelvic vasodilation, meaning blood pools away from the central circulation. You absolutely must instruct your patients to stand up slowly so they don't faint and hit their head on a hard bathroom floor. Second, the cushion contraindication. Tell your patients to throw away those donut cushions. I know they look comfortable, but that circular opening exerts outward lateral pressure right on the gluteal cleft. That engorges perineal veins and actively worsens local edema. Have them sit on a flat, semi-firm surface instead. And lastly, temperature control. The water has to be lukewarm, never hot, meaning never over 42 degrees Celsius. Post-surgical tissue has completely altered sensation, so a patient could easily suffer a severe burn without even feeling it in the moment. To really anchor everything we've talked about today in rock-solid evidence, I want you to consider this finding from a landmark 2005 clinical trial by Tajarian and team. They confirmed that regular warm sitz baths significantly reduce post-operative anal sphincter hypertonicity, leading to lower pain scores and a decreased need for narcotic analgesics. The data just doesn't lie. This is not about feeling fresh and clean. This is about actively downregulating a severe physiological pain response and getting our recovering patients off systemic opioids much faster.
So I'll leave you with this final thought. The next time you're mapping out a post-op recovery plan or instructing a patient at discharge, how are you going to frame it? Will you just look at the sitz bath as a simple post-op wash? Or will you leverage it for what it truly is, a vital 15-minute neurovascular intervention? Keep that 15-minute window firmly in your mind because it just might be the absolute most powerful tool you have in your post-op arsenal. Thanks for joining me on The Explainer today, and keep learning.